Now we're going to talk about the adrenal problems. You have got to have adrenals to handle stress, and you've got two parts. You've got the adrenal medulla, and you've got the adrenal cortex. Now let's talk about the medulla first. With the adrenal medulla, you should always think epi and norepi. Epi and norepi. And the major adrenal medulla problem that we have is pheochromocytoma. Pheochromocytoma. These are just, this is when, I should say, you have benign tumors that secrete epi and norepi in boluses. So see, you're walking around Walmart one day just having a good time, and all of a sudden you get a bolus of epi and norepi. Well, what's going to happen to your heart rate? Increase blood pressure. Increase, and you're going to be just flying all over the store shopping, aren't you? Okay? And you're going to say to your friend, my heart's racing out of my chest. I just feel like I've got a pounding headache. I'm flushed. I'm dying for ready. Take my blood pressure. So y'all find that machine at Walmart, right? And you put your arm in it, and you've got high blood pressure. All right. Well, here's the deal. And then you get to feeling better after a while. People have these spells, I call them, often enough that they finally go to the doctor and tell the doctor what they have been experiencing. And the doctor says, sounds like pheochromocytoma. Let's do a VMA test, vanilla mandelic acid test. That's why we just say VMA. Now, y'all, from the name of the test, what food product might just alter the test, and I promise it's not a trick? Vanilla. Anything with vanilla in it. So now you got to know how to cook to pass NCLEX 2, you see, okay? Now then, it's a 24-hour urine. Well, who do you think is going to teach the patient about a 24-hour urine? The nurse. So drop on down to the star. With a 24-hour urine, you should discard the first voiding and save the last voiding. And your teacher told you that they collect for 24 hours in a special container, and if they even miss 1 cc, they got to do what? Start the test all over again, right? And be sure and tell your little patient, if they're collecting it at home or in the hospital, that they do not have to void directly into the large container, okay? Because what they'll do is they'll pick up the container and try to walk around with it down the hall to the bathroom, okay? And then they end up dropping the whole thing in the floor. You would be surprised how often that happens. They can void into something smaller, okay? And then pour it into the special container. It's a 24-hour urine, and you're looking for increased levels of epi and norepi, also known as catecholamines, okay? Y'all, if they think that I have got pheochromocytoma, why can't, while I'm at the doctor's office, why can't I just give the lab a specimen while I'm there and let them check that urine for increased levels of epi and norepi? That's right. I may not be having a bolus at the doctor's office, right? You only have these spells every now and then. That's why it has to be a 24-hour urine. Now, before I move on to surgery, let me say this. Aren't there other things in life that can make you get a surge of epi and norepi? Yeah, what if you exercise really, really hard? Or smoke a whole bunch? Yeah. What if I have a screaming PMS fit? What am I going to get a surge of? Not that I would ever do that, okay? You're going to get a surge of epi and norepi. So my point is this. Other things can alter the test. So starting the day before and during the collection, they've got to stay calm, no change in activity. That's a teaching point. And treatment is surgery, where they just take out the tumors. Take out the tumors. All right, let's move on to the adrenal cortex now. You see, sometimes y'all in test questions, they may say just adrenal gland. And when they say adrenals or adrenal gland, you don't really know if they're focusing on the medulla or the cortex. But if they do get specific, at least you'll know what chemicals to think about. Okay, if it's medulla, epi, norepi, if it's cortex, that's when you think steroids. Okay? And you know that you've got your glucocorticoids, mineralocorticoids, and sex hormones. Now, there are 4 major actions listed under glucocorticoids. Okay? Look over to the side. I have given you some examples of some glucocorticoids in the box, all right? Common ones that we all use. And let me emphasize, a steroid is a steroid, y'all. We make them endogenously inside our body, but we can also take steroids in a drug form. And when you're given a steroid in a drug form, you need to know what kind of steroid it is, because different steroids have different types of actions, you see. That's what we're going to focus on. Now look at the second little box there. It says we secrete steroids normally, but the signs and symptoms are more pronounced when the patient is receiving oral or IV steroids, okay? So right now my body's making steroids, and I'm not really having all of these symptoms that we're about to go over. But you put somebody on a steroid, or they start developing a disease where they're making too many glucocorticoids, and they're going to become symptomatic. Also, look under glucocorticoids. The first thing you see there is change your mood. Some people, when they get on a steroid like prednisone, they get depressed, full-blown depression. A lot of people get mean. You give somebody a shot of Decadron, long-acting, and they'll be mean for a month, okay? And their wife will call back to the clinic and say, what did you give him? Don't you do it anymore. He's allergic to it. He's been mean, okay? They think it's an allergic reaction, okay? So some people get mean. Some people just get crazy. They absolutely go psychotic. And you'll see them going naked down the hall one day, leaving with their IV pole. Psychoses, okay? Insomnia can occur because steroids give us energy. If you've ever had a sports injury or something, they'll give you a shot of Decadron or cortisone in your knee or whatever you've hurt, and then they'll tell you, now rest. Stay off that lead. Well, the people can't rest because they've got so much energy, they just want to play tennis or whatever they're not supposed to be doing. So change your mood, suppress your immune system is another one that we have. Alter defense mechanisms. Everybody in here knows that when you're on a steroid, you can't fight infection, right? You're immunosuppressed. Break down protein and fat. Well, in a little bit, we're going to talk about Cushing syndrome person, and you're going to see that their arms and legs get real skinny because they're breaking down protein and fat. Another person I think of here is a child on steroids. When you have a child on steroids, they're breaking down protein and fat, so are they going to grow correctly? No, their growth can be inhibited in children. And inhibits insulin. Well, if you have inhibited your insulin, that means your blood sugar's going to go up. Blood sugar goes up. If your insulin's not working, blood sugar goes up. So now, anytime you've got somebody on steroids in the hospital, I guarantee they're going to start doing finger sticks on them to check their blood sugar, and the doctor's going to order sliding scale insulin for them. You see, it's medication-induced diabetes. All right, so let's review that. They change your mood, suppress your immune system, make you break down protein and fat, and inhibit your insulin. So I'm hyperglycemic now, aren't I? Okay? And remember, like I said, the mood changes. You may be depressed. You may be, another one that I need to say about the mood is euphoric. Some people become happy when they're on their prednisone, and they don't want to stop taking it. They love it. They love the energy. All right, now let's look at mineralocorticoids. Aldosterone is the major mineralocorticoid. And I told you we were going to talk about it every single day, so here we go again. We learned yesterday that the normal action of aldosterone is to make you retain what? Sodium in water. We're going to add a new sentence today. Makes you lose potassium. Because sodium and potassium have an inverse relationship. Okay, notice on your handout in bold letters, I've got too much, not enough. Figure out with your friend what's going to happen to the vascular space in the serum potassium when you have too much or not enough. All right, now then, let's look at the too much now. If you have too much aldosterone, you're going to retain too much what? Sodium in water, so you're going to go into a fluid volume. Excess, overload, okay? Now, what's going to happen to your serum potassium? It's going to decrease because if you're retaining sodium, you're losing Potassium. So the only two things I could ask you about there would either be fluid volume excess or hypokalemia, right? Okay. Now, not enough. If you do not have enough aldosterone, you're not going to be able to retain sodium in water, so you're going to lose sodium in water and go into a fluid volume deficit. So if you're losing sodium, you're retaining potassium, so hyperkalemia is what we're worried about there. Hyperkalemia. And then also we have sex hormones, and we're going to talk more about those in just a little bit, especially when we start talking about the Cushing syndrome person. Now, adrenocorticotropin hormones, also called ACTH, and cortisol mean the same thing. They refer to the hormones of the adrenal cortex. And when you hear the word steroid, this is referring to the same things. Also, as you can see on your handout, the word hypercortisolism is just another word for too many steroids. That's what I meant earlier when I said that in textbooks they always get it confused because they'll say glucocorticoids one minute, then they'll say cortisol, then they say ACTH. All of that means steroids to us, okay? Now then, let's look at adrenal cortex problems. And the first one we have is Addison's disease. Adrenal cortical insufficiency. Underline the word insufficiency. And if this patient is insufficient, do they have enough glucocorticoids, mineralocorticoids, or sex hormones? No, they're insufficient. That's why I said earlier, add steroids. Remember, with Addison's, we need to add steroids. That's just a way to remember it. Focuses on aldosterone. Normally, aldosterone makes us retain sodium in water and lose potassium. Do we all agree on that? Yes, okay. Now we don't have enough. We're insufficient. So we're going to lose sodium in water and retain potassium. So the serum potassium will be high. That's right. The majority of the signs and symptoms come from hyperkalemia initially, but it's going to get worse, okay? Some of the signs and symptoms just have an unknown etiology. So let's look at our signs and symptoms. Muscle weakness, decreased bowel sounds, anorexia, nausea, GI upset. All four of those, y'all, can be from the potassium troubles that they're getting into. Remember, the muscles are affected with potassium. Hyperpigmentation and hypoglycemia. Now, ask I don't know why they get hyperpigmentation, but I do know about the hypoglycemia. See if you and your friend can figure out why the Addison's person gets hypoglycemia. Think about how steroids affect the blood sugar. Okay, discuss it. What do steroids do to your blood sugar? Increase your blood sugar. So here I don't have enough, all right? I do not have enough steroids, so my blood sugar's going to drop. Blood sugar's going to drop. Let's go back to the top of the page where it says Addison's disease. There's three things I want you to write down. And the first thing I want you to write down is not enough steroids. Not enough steroids, shock, and high potassium. Shock and high potassium. Those are the three major things you need to think about when you think of Addison's disease. All right. Now, back down to signs and symptoms. The last thing there says hypotension due to increased capillary permeability and decreased ability for the vessels to constrict. But also they're becoming hypotensive because we are losing what from our vascular space? Sodium and water. Sodium and water. Now, if you check this patient's blood or urine for adrenocorticotropin hormones, would they be present or absent? Absent, because we're talking about, again, adrenocortical, what's the word? Insufficiency. Adrenocortical insufficiency. Treatment, combat shock, fight shock. Now, why are we having to fight shock? Because we are losing what? Sodium in water. processed fruit juice and broth is good for this person because it has lots of what? Sodium. That's a good thing here. They need more sodium. Of course, we're going to do I&O. And if this patient is losing sodium, their blood pressure will probably be low because they're not just losing sodium, they're also losing water with it. They're losing volume. They will probably be gaining or losing weight. Losing. So what's their major nursing diagnosis? Fluid volume deficit. We're worried about shock. They will be placed on a mineralocorticoid, drug aldosterone, known as Florinef, okay? Because, y'all, isn't that what they're deficit in? Yes, that's what they're deficit in. And weight is very important in adjusting their medicines, okay? Think about that. If I gave you each some aldosterone pills, Florinef pills, what would you start retaining? Sodium and water, and your weight would start to go up, okay? So see, these people have to learn to watch their weight at home and adjust their medicines accordingly, all right? Now, look at the rule on your handout. When on a medicine where weight has to be monitored, keep weight within 2 pounds plus or minus of their norm, okay? Now, patient has an overnight gain of 7 pounds. What do you think? Is that too much? Yeah, that's way too much. I have to worry about heart problems and pulmonary edema. That's what I'm worried about here. Heart problems and pulmonary edema. So what needs to be done with the dose? Decrease or hold. Decrease or hold. And you may be saying, well, which one is it? The patient learns how to manipulate the medicine. You'll never have to select like an answer like that on boards, okay? Because we're just talking in general here. Also, overnight our patient has gained 7 pounds, okay? Excuse me, overnight lost 7 pounds. All right? What are you worried about now? Deficit, shock, right? Yeah, I'm worried about shock. So what needs to be done with the dose? Increase the dose. You're taking care of a patient in the hospital who is on Florinef and they're developing edema, or you notice that their blood pressure's up and they have an 8 a.m. dose of Florinef ordered. What should you do? Hold it and call the doctor. Hold it and call the doctor. Y'all, if you gave it, what could you throw your patient into? Pulmonary edema, heart failure, fluid volume overload. All right, you're taking care of a patient in the hospital and you notice that their blood pressure steadily going down and they're on Florinef. Obviously, what needs to be done with the dose? Increase the dose. Now, I'm sure we've all heard of an Addisonian crisis, right? When you are in an Addisonian crisis, it's the same thing as Addison's disease, just more pronounced. It's worse. You're really losing tons of sodium in water. This is where the patient has severe hypotension and vascular collapse can occur. All right. Now, I bet your teacher told you this. When you are on steroids, you never stop taking them abruptly, right? Yeah, when you've got a patient on steroids, they're supposed to taper off their steroids. You don't just stop taking them one day. Now, let's think about that. When I take steroids and take steroids and take steroids, I'm going to get the appearance of Cushing's disease, right? Because that's what too many steroids are. That's Cushing's disease. But one day, you know, what happens to your own adrenal glands when you're taking an exogenous form of a steroid? They just quit working, don't they? They go to sleep. So my own adrenals are not making steroids. I'm dependent upon this exogenous dose. All of a sudden today, I decide, hey, I'm going to quit taking that steroid. Bam, throw it in the trash. So I didn't take my exogenous form, and my body's not making steroids. So all of a sudden, I do not have any steroids in my body, right? Could I go into an Addisonian crisis? Yes, absolutely. All right, now let's look at Cushing syndrome. I just differentiated for you on your handout the difference between Cushing syndrome and Cushing's disease. On your test, it wouldn't matter which way they stated it, whether it's syndrome or disease, the answers would be basically the same to the questions, okay? Cushing syndrome is exogenous administration. Someone who is taking steroids for the treatment of asthma, autoimmune disorders, organ transplant, cancer, chemotherapy, allergic responses. Okay, they just call it syndrome. Whereas if it's Cushing's disease, you develop that disease endogenously, like bilateral adrenal hyperplasia. In other words, your body's making too many steroids. Pituitary adenoma increases secretion of ACTH, malignancies, adrenal adenoma, carcinoma. Now, these patients have too much glucocorticoids, mineralocorticoids, and sex hormones. So the first thing you need to remember with Cushing's is too many steroids. That's the first thing you need to remember. Too many steroids, all of them. And you can see on your handout that I have a list of symptoms there, and I've got them grouped in clusters on purpose. One group of symptoms is because you have too many glucocorticoids. One group is because you have too many mineralocorticoids. And the other is because you have too many sex hormones. Now figure out which group is what. First group? Yes, that's because that first group is because you have too many glucocorticoids. Second group? That's the sex hormones. Third group? Mineralocorticoids. Now that I know that my body is making too much mineralocorticoid, aldosterone, look out to the side. My major nursing diagnosis is going to be a fluid volume excess. All right, at the bottom of the page, since this patient has too much mineralocorticoid aldosterone, the serum potassium will decrease. There you go. Decrease. Because you're holding on to sodium in water, so you're going to lose potassium. If you did a 24-hour urine on this patient, the cortisol levels would be high. Because remember, cortisol is just a fancy word for steroids. And with Cushing's disease or syndrome, you've got too many steroids. Treatment, adrenalectomy, may be unilateral or bilateral. Well, if both adrenals are removed, you're going to have lifetime replacement, because can you live without steroids? No, you got to have them. Now, this person needs a quiet environment. Now, here's the deal with that. Anytime your steroids are messed up, you can't handle stress. So they need quiet. And what does the patient need in their diet pre-treatment? Discuss those 4 things with your friend, and then we'll go over it. Okay, what you going to do with potassium in their diet? Increase it, because they're losing theirs, aren't they? What you going to do with sodium? Decrease it. They're already in a fluid volume excess, so we're decreasing sodium. Protein? Increase it. They're breaking it down. Now here's the tricky one, calcium. Did you like the hint to the side? Okay, so what you going to do there? Increase the calcium. Now, we mentioned this yesterday. What we said yesterday was that steroids decrease serum calcium, and we stopped. Today, I'm telling you the why part, by making you excrete it through the GI tract, you see. Now, let me talk about that just a little bit more. Let's say I'm on prednisone for my rheumatoid arthritis to decrease the pain and inflammation of my disease, right? Okay, so I take my prednisone this morning, and we just got through saying that steroid is going to make my serum calcium go down, right? Okay, but I got a way to fix that calcium trouble. I just come over here to my bones and pull, that's right, from my bone and put it in my blood. Therefore, my serum calcium just went up. Okay, so my calcium's fixed for today. But tomorrow I get up and I take a what? Prednisone. And what do I do again? It makes my calcium go down, and I go over here to my bones to get me some more. So my point is this. The more you take steroids, what kind of bones are you going to have? Brittle, osteoporosis. Steroids make you have brittle bones. That's why you'll see people who have been on steroids for a long time, for whatever reason, and they'll sneeze one day and crack 3 ribs. Or you'll turn this person in the hospital, and if you don't handle them gently and you get them in the middle of a bone, you can snap their bone in 2. Or you're going to do CPR on somebody one day who's been on steroids, and every time you compress the chest, what do you hear? The ribs cracking, okay? All right. Now then, also on your handout it says to avoid infection. Remember, anytime you've got too many steroids, you've got somebody that's immunosuppressed, right? And what might appear in their urine? Figure that one out. The top 3 answers I get here are glucose, ketones, protein. Write those down. Glucose, ketone, protein. Now then, which one's wrong? Now you're saying, well, why don't you make me write it down, okay? So you won't forget it. Which one's wrong? Protein is wrong. Scratch it out. Put you a big X over it. Y'all, the only time we have proteinuria is when we have glomerular damage. I hadn't even said glomerulus since I met you yesterday. Now, have I? No, that'll be on the last day of the class. You can say glomerulus, okay? All right. This person doesn't have glomerular damage, but they will have glucose and ketones because steroids make your blood sugar go up, so the excess is going to spill over into the urine. And also steroids make you break down fat, which also makes you produce ketones. Now, you still may be saying, well, why, if you're breaking down protein, why don't we have proteinuria? Because, y'all, how big are protein molecules? This big. Okay? They're huge. And they cannot leak through the glomerulus unless you have what? Glomerular damage. Holes. Okay? And we hadn't got to that yet. All right. All right, let's talk about diabetes now. We mentioned diabetes yesterday when we were talking about the vascular space, okay? Y'all remember that? The PID and the osmotic diuresis? Okay, we're going to talk about that again. Type 1, insulin dependent. They have to take insulin, and it usually starts in childhood, and the first sign may be DKA. DKA, diabetic ketoacidosis, and we'll talk more about that in just a little bit. Now, the patho, you have to understand the patho or you will always be confused about the diabetic patient. You have to have insulin to carry glucose out of the vascular space over to the cell. Since there is no insulin, the glucose just builds up in the vascular space. The cells are starving, so they start breaking down protein and fat for energy. And when you break down fat, you get what? Ketones, which are just acids. And now this patient is acidotic. Is it respiratory or metabolic? Metabolic acidosis, which we talked about yesterday. Now we have lots of signs and symptoms coming about. The 3 Ps. Hyperglycemia equals 3 Ps. Polyuria is the first one with accompanying weight loss. Now, we said yesterday that we got polyuria because what are the kidneys trying to help you do? Get rid of the sugar particles. But when you lose sugar particles, do you also lose volume? Yes. So that's why we wrote this down yesterday. Polyuria equals shock. Remember that? Polyuria equals shock. Polydipsia is thirst. Well, if you've been losing a lot of volume, you're going to be thirsty. And polyphagia, hunger. Your brain cells are hungry, aren't they? Because they aren't getting any glucose. But if this person ate more, would it do them any good? No, because they still do not have any what? Insulin to carry the glucose into the cell, you see. You can have all the glucose in the world, and if you do not have the insulin, it's never going to get into the cell. Sugar doesn't do you any good until it can get into the cell. Will oral hypoglycemia agents such as glucotrol, micronase, or diabeta work in this patient? No, they have to have what? Insulin. They've got to have insulin. Now, I've listed for you here 2 different phenomenons you may see, Samoji phenomenon and the dome phenomenon. And when you're studying, just read over those definitions that I have listed for you there, okay? Now, let's move on and look at type 2 diabetes, non-insulin dependent. These people don't have enough insulin, or the insulin they have is no good. So in this person, y'all, is their pancreas still working? A little bit. Yes, that's important for you to know. Their pancreas is still working a little bit. These patients are usually overweight. They can't make enough insulin to keep up with the glucose load the patient is taking in. And this type of diabetes is not as abrupt as type 1. Think about type 1 for a minute. Remember, you got the 3 Ps, you're in metabolic acidosis, waking up in the ER usually, right? This is really sneaky. It's usually found by accident. Or the patient keeps coming back to the doctor for things like a wound that won't heal or repeated vaginal infections. Why does this patient have trouble with wound healing and repeated infections? What is their blood full of? Sugar. Who likes sugar? Bacteria. Bacteria thrive in this environment. Treatment. We start with diet and exercise, and then we might have to add an oral agent. You see, in some people, diet and exercise fixes the problem. Maybe they just need a little control, all right? So diet and exercise, then they might have to add an oral agent. Then if that doesn't work, like if you have somebody that's really non-compliant, they'll have to start taking what? Insulin. All right, now general treatment of diabetes. The majority of the calories should come from complex carbs, then fat, then protein. Now the major thing I want you to get out of that is this. I'm limiting the protein for a reason. We're limiting the protein because of the sentence out to the side. Diabetics tend to have renal disease. Renal disease. And everybody knows that when you have kidney troubles, you limit protein, right? And we'll study more about this and why they have the renal disease in just a little bit. Now, why are diabetics prone to coronary artery disease? Because sugar deposits and destroys vessels just like fat. Everybody in here understands what happens to your vessels when you have a high-fat diet, atherosclerosis and that sort of thing. Sugar does the same thing. So the diabetic not only has to watch their sugar, they have to watch their cholesterol and triglycerides and everything too. They've got double damage to their vessels, you see. High-fiber diet is good for this person because it helps keep the blood sugar steady. They may even get to decrease insulin. High fiber slows down glucose absorption in the intestines, therefore eliminating the sharp rise and fall of the blood sugar. Now let's talk about that for a second. You know, most of the time when you're at school and you have a break, you run and get you a candy bar and a Coke. That's what a lot of people do. So what is going to happen to your blood sugar? It's going to shoot up really high, and then in 30 minutes it's going to do what? Bottom out. So see, y'all, I pointed my finger really high and then really low. Those are extremes in the blood sugar. Now here's what you write down. Extremes equal vascular damage. Extremes equal vascular damage. So that's why we like the blood sugar to be steady, and that's what a high fiber diet will do. Wait until the blood sugar normalizes to begin to exercise, because you know in the beginning, when you're first diagnosed, your blood sugar is really fluctuating a lot. So we're just letting it normalize. And what should the patient do pre-exercise to prevent hypoglycemia? Eat something. Piece of fruit, something like that. And they need to exercise when blood sugar's at its highest or lowest? Highest. It wouldn't be smart to go running with your low blood sugar, now would it? No, because where are you going to wind up? In the ditch, right? Passed out in the ditch and everybody's looking for you now, right? Can't find you because you're passed out in a ditch somewhere. Exercise the same time and amount daily. We're trying to establish a routine. Routine is very important for the diabetic. Now, how do oral agents work? Well, the magic word I want you to think of first is stimulate pancreas to make insulin. Stimulate pancreas to make insulin. That's the number one thing I want you to remember when you're thinking about oral hypoglycemic agents, but also note, not all agents stimulate the pancreas, okay? But as a brand new nurse, that's the first thing I want you to think of, all right? And then I've made you a little chart there to show you what some of the other actions are. All right, now let's talk about the insulin dose. How is the insulin dose determined? Well, the dose is increased until the blood sugar is normal and until there is no more glucose and ketones in the urine. Glucose and ketones in the urine. Regular's clear, MPH is cloudy. Which one do you draw up first? The clear, the regular. And what is the only type of insulin you can give IV? Regular. All right, now a blood test. Hemoglobin A1C gives an average of what your blood sugar has been over the past 3 months. Okay? So that's a way the doctor can look at your hemoglobin A1C and see if you've been telling the truth about your blood sugar, right? Because it's going to give you an average of what it's been for the past 3 months, no matter what you say, okay? Now, patients should eat when insulin is at its peak. That's why we have the little box out to the side. Peak, you need to think hypoglycemia. Y'all think about that. When your insulin is peaking out, working the hardest, that's when your blood sugar will be at its lowest. So that's why you were told to memorize the peak so you could hurry up and get a snack in the room, right? The patient needs a snack, needs something to eat during that time. Now, what happens to your blood sugar when you're sick or stressed? It goes up, doesn't it? Yes, it goes up. It says on your handout, a normal pancreas can handle these fluctuations. An increase in the blood sugar when sick or stressed is a normal reaction to help us fight the illness or stressor. But if I'm a diabetic and that stress or illness makes my blood sugar go up, I've got to remember to do something. What must I do to my insulin dose? Increase the insulin dose. Increase the insulin dose. That's what the diabetic needs to remember. increase the insulin dose. If they do not increase their insulin dose in the presence of that higher blood sugar, see, it's higher than it's been being, right? If they don't increase their insulin dose, what major complication are they headed towards? DKA. Here's your formula. Illness plus diabetes equal DKA. Illness plus diabetes equal DKA. That's why they must be watching their blood sugar so closely when they're sick or stressed out. Now, rotation of sites. Rotate within an area first. Rotate within an area first. And all I mean by that is this. When you are administering to yourself insulin injections, you use one side at a time. This week, I'm using my right arm, okay? And I'm going to use up all these sites. And then don't use that site anymore for 3 to 6 weeks, because you've got to give that site time to do what? Heal. If you don't allow it to heal, that's when you get connective tissue and scar tissue, and your teacher called it lipodystrophy. And when any of that stuff occurs, what just happened to my insulin absorption? Decreased. You see, I just lost a site. You don't just randomly give yourself shots every day. That's what they do in the hospital, I know, but not when you're taking care of yourself at home. You see, I want to conserve sites as long as I can because I have a chronic disease, don't I? Do we aspirate insulin? No. Too much tissue trauma. Too much tissue trauma. It's why we do not aspirate it. The diabetic doesn't need more tissue trauma. What's another drug that we never aspirate? Heparin, Lovenox. Heparin and Lovenox, same reason. Too much tissue trauma. Okay, let's look at our signs and symptoms of hypoglycemia now. Write down as many symptoms as you can think of all by yourself. And then I'm going to start saying them in a little bit, and you can see which ones you have like me. So write down as many as you can think of. Shaky, nervous, increased pulse, cold and clammy, nausea, confusion, headache. All right, those are your routine general signs of any kind of hypoglycemia, all right? But remember, hypoglycemia is very dangerous in the diabetic because do they have good compensatory mechanisms to bring their blood sugar back up? Okay? So what should the patient do when they start feeling like that? Eat something, a simple sugar. Maybe drink a Coke. Eat some candy. Now, I said a simple sugar because a simple sugar will get your blood sugar up really fast. That's right. Like milk will even get your blood sugar up really, really fast. Okay? Now, after the blood sugar is up, what should they do? Eat some more. A complex carb and a protein. Complex carb and a protein. Cheese and crackers, peanut butter and crackers. Drink some more milk. Because, y'all, what if you didn't follow the simple sugar with the complex carb and a protein? What's going to happen again? Bottom out. And every time we bottom out, we lose a few brain cells. You enter a diabetic patient's room and they are unconscious. Do you treat this patient like he is hypo or hyperglycemic? What you think? hypoglycemic. Y'all, can you have unconsciousness with both conditions? Yeah, you can be unconscious with hypo and hyper. But the one that's the most dangerous is hypo because of the brain. So you run, go get you a couple of amps of D50 and you push it IV and you keep your fingers crossed that your patient wakes up, right? Now, when they awaken, what should you do? Make them eat. They need to drink some milk, eat some peanut butter and crackers, something. Now remember, when you're pushing D50, it's a big amp of it, isn't it? It's pretty big. It's hard to push, so when you start pushing it, just know it's going to be hard to push. You just have to keep with it. And if you have a choice, you need a large bore IV. It's going to push easier that way, but it's still hard to push, okay? Physically, I'm talking hard to push. Now, also injectable glucagon can be used, and it's used when there's no IV access, okay? It's an IM. Whether you use D50 or injectable glucagon, both of those are going to give you temporary increases in the blood sugar. Temporary increases in the blood sugar. Prevention is to eat and take insulin regularly. And y'all know those cute little snacks that just appear at the nursing station at weird times of the day, like 10 o'clock, 2:30, 8:30 at night? Who's supposed to get the little snacks? The patient, right? Right. Not you. If he's asleep, you need to go wake him up, right? And make him eat something, even if they get mad at you, because their blood sugar might bottom out if they don't. Now, complications. The first complication, diabetic ketoacidosis. Anything that increases the blood sugar can throw a patient into this, like infection or illness or skipping your insulin. You see, all three of those things will make your blood sugar go up, right? Maybe the very first sign of diabetes, and you have all the usual signs and symptoms of type 1 diabetes. So here we go. Not enough insulin. Blood sugar goes sky high. You get the 3 Ps. We get the fat breakdown, which leads to acidosis. And now that I'm acidotic, I start co-smiling because I'm trying to blow off what? CO2 to compensate for the acidosis. And as this patient becomes more acidotic, the LOC goes down, because what organ doesn't like it when your pH is messed up? Brain. So treatment, find the cause. What's the illness? If it's an illness, we got to treat it. Hourly blood sugars and potassiums, because of the next sentence. We're giving IV insulin. And insulin will decrease the blood sugar and potassium by driving them out of the vascular space into the cell. So we said this yesterday. We said yesterday that when you're giving IV insulin, there are 2 hypos to worry about. Hypoglycemia and hypokalemia. Hypoglycemia, hypokalemia. That's why it says on your handout to do hourly blood sugars and potassiums, because of those 2 hypos. Well, now that we're messing around with the potassium, do you see why we've got us an EKG going? Yeah, we got to worry about arrhythmias. We're going to do hourly outputs. Hey, y'all, when somebody first starts going into DKA, what is their urine output like? Polyuria, right? But by the time you get the patient up in the ICU, could they already be oliguric and anuric? Yeah, so we've got to worry about their kidneys here. Check out the ABGs, of course. You know they're acidotic, right? IV fluids. Out in the left margin, remember this? Polyuria equals shock. Polyuria equals shock. So these people come in shocky, don't they? That's why it says on your handout to start normal saline, because normal saline is what class of solution? Isotonic. And isotonic solutions go in the vascular space and they stay there and build up and make my blood pressure come back up. Okay, that's good. They usually start 2 antecubital IVs, 2 ACs, and they just put that fluid to them as fast as they can stand it without blowing out their veins, okay, trying to replenish the volume. But look at the next sentence. Then, when the blood sugar gets down to about 300, hey, y'all, if it's getting down to 300, it must have been pretty high, right? If it's getting down to 300, then we switch one of the IVs to D5W to prevent throwing the patient into hypoglycemia. Because, y'all, if you still got a blood sugar of 300, what are you still giving to your patient? Insulin. That next dose of insulin could do what? Bottom out the blood sugar. So you're just trying to offset hypoglycemia there when you switch one of those IVs to D5W. And the doctor will tell you when they want that done. Anticipate that the doctor will want us to add what to the IV solution at some point? Potassium. Remember, we're inducing hypokalemia in this person as well. Now, HHNK, hypertonic, hyperosmolar, non-ketotic coma, underlying non-ketotic, that's what makes this different. It looks like DKA, but there's no acidosis. Well, you can't be in DKA if you're not acidotic, right? This is the patient that comes to the ER and they're diabetic and everybody's like, okay, they're in DKA. Yeah, it's DKA. I just know it's DKA. And then they draw ABGs and I said they are not what? Acidotic. So everybody's like, well, what is it then? Here we go. They're making just enough insulin so they're not breaking down body fat. If they're making just enough insulin, what type of diabetic is this? This is the type 2 diabetic. So they're making just enough insulin so they're not breaking down body fat. No fat breakdown, no ketones, no acidosis, right? Okay. Will this patient have Kussmaul's respirations? No, because they're not acidotic, right? So in the NCLEX world, type 1 diabetics get DKA, type 2 get HHNK. In the real world, they can swap them around. A type 2 can get DKA. But see, if you go into boards thinking like that, you're going to be all confused. This is how you learn it for NCLEX, all right? Okay. Now, complications. Well, if I had to pick one complication of diabetes, it would have to be vascular problems from head to toe, starting at the eyes and going to the feet and catching every organ in between. You'll see what I'm talking about. They develop poor circulation everywhere due to vessel damage. Sugar irritates the vessel lining, all right, and you get and also accumulation of sugar will decrease the size of the vessel lumen, therefore decreasing blood flow. So now we get diabetic retinopathy. Can this lead to blindness? Yes. Y'all, your retina, is it very vascular? Yes, it's very vascular. Okay? Don't you remember when you faked it and you check it off with the ophthalmoscope? Okay? Did y'all have to check off with the ophthalmoscope at school? And y'all all faked it, acting like you could see the retina. Oh, yes, I see it. We know you didn't see it, okay? But the retina is very vascular, so those little tiny vessels become damaged by the sugar, which leads to blindness. Nephropathy, kidney damage. Y'all, are kidneys vascular? Very vascular. That's why so many diabetics end up on hemodialysis. Also, neuropathy, nerve damage. Sugar kills nerves. This is where you get into the sexual problems like impotency. You know, you'll hear people, a man come to the doctor, 89 years old, had never been to the doctor my whole life. But if that happens, who are they calling? 911, right? Okay? Well, they already have nerve damage. That's why routine physicals are good. They can offset problems from ever happening. Now, number 2, foot and leg problems, pain, paresthesia, numbness. Okay? This is where you'll hear about a diabetic who gets in water that's way too hot and they burn their feet. Another common scenario is they walk around with a little rock in their shoe all day, and they never felt it. Now they have a hole in their foot, okay? They can't feel. Or you'll hear people say things like, my feet and just burn so bad at night I can't even sleep. That's the neuropathy that's occurring. Now, teach the person everything you know about foot care right now. Come on, talk to each other. Cut those toenails how? Straight across and not too short. Straight across and not too short. And do we have to have a doctor's order to clip toenails? Yes. Okay. If you start cutting toenails way too short, they have a tendency to start growing downwardly into the tissue. Okay, and that you don't want a diabetic to get an ingrown toenail. Okay? All right, also wear good shoes. Well-fitting shoes. They need to wear shoes all the time. Girls, it's not like what we do. If we find us a pair of shoes we want to wear for 2 hours Friday night, we don't care if they fit, right? We are going to wear them and force because we can stand it for 2 hours, can't we? Right? Should a diabetic do that? No, it can lead to wounds on the feet that never heal. Okay? Avoid harsh chemicals. Avoid harsh chemicals on the feet, like alcohol and betadine. Dry well between the toes, because who likes to live between the toes? Bacteria. And inspect feet how often? Every day. Every day. All right, now, other problems associated with neuropathy, neurogenic bladder. Your bladder doesn't have tone, which can lead to one of two problems. You either will wind up with fluid retention, urine retention, I should say, because your bladder can't contract, or you may wind up incontinent, okay, because there's no tone. It just depends on the patient. And then also gastroparesis. This is when the stomach emptying is delayed, so there's an increased risk for aspiration. And then also with an increased sugar throughout the body, there's always an increased risk for infection, right? Okay. Enough on the endocrine system.